So I know we have a lot of attorneys and mental health professionals here today, and before I proceed with the next section, was kind of curious about what kind of cases you're seeing and whether the use of polypharmacy, multiple medications with children is something that you see frequently. Anybody have an example or a case that they've struggled with? So I'm wondering whether you're seeing whether you're an attorney or a mental health professional, whether you're seeing a lot of kids coming in with multiple medications on board, and
where we work, they're almost all on medications. 80%, I would say.
where is that?
YRTC in Geneva.
Ah, okay, yeah.
Yeah, a lot of them are.
So what do you do in that situation?
We don't have a lot of say as far as what we noticed some of the sleeping a lot during the day.
Mm-hmm.
We do have sleep steady type things where we have to keep track. If the girl's not saying she's not sleeping, we have night staff. We have charts where we have to keep track for 2 weeks whether or not they actually are sleeping
Yeah.
in the nighttime or if they're sleeping during the day.
Okay.
But we don't really have a lot of say as far as
What to do in those situations? Yeah. Okay. Other people seeing a lot of this in their community?
In CPS, we get from obviously with tons of kids, with tons of medications. I mean, again, only as the legal guardian do we have any say in that. I mean, you don't know as much as a doctor right now, or we always try to take into account what the parents think about it. So, you know, I would agree with you, but we don't have a lot of knowledge for one thing and a lot of control over the other.
Okay. Do you feel like there are enough behavioral treatments available to you? If you wanted to refer a kid as a first try rather than putting him on a medication, are those services available? No?
I would say they are. I mean, it's just finding the time. I think the schools are pretty good about that, like you said. At least in Lincoln, I think there's a lot of working with a certain therapy office who goes into the school and
Yeah.
also sees kids outside of it. So I would say so, yes. But it's just a matter of finding the time. And obviously, those people are overloaded too.
And your perspective is a little bit different with CPS. By that point, kids are probably getting more services than if they're just out in the community. I think that's where we see a lot of problems before kids even get into systems. Yeah.
The big problem that I see in the juvenile justice system is that by the time the kids get involved in the system, they're already on not one, but multiple
Yeah.
drugs.
Yeah.
And you don't know what the baseline is. You
Right.
don't know if it's a behavioral problem or
Right.
a neurological problem. And the only way you can find out is to do a full purge of it, and which can be real risky business too.
Right, and you certainly wouldn't want to do that in a community-based setting. Yeah, do a washout. Yeah.
We have a daycare, not a daycare, we have something called Behaving Child Center, where our youngest kids, our elementary kids, will go, and there's a contact with the LPS, the
Yeah.
public school system, and they work hand in hand where the child will be behaving for a period of time during the day, and then they integrate them back into the school schedule. And that seems to be pretty effective with my youngest people.
Okay.
And my elementary kids, and I don't know how much medication they use, or, you know, how many of the kids there, but in visiting the center and stuff, it's all behavioral, and they
Right.
do really good work.
Right, right. So a lot of structure, a lot of positive reinforcement. Yeah, we're going to talk a little bit about some of those interventions, but yeah, I've heard this good program. Other comments, thoughts, frustrations? Yeah.
It seems kind of like when they adjust medication, the psychiatrist and psychologist, you know, somehow doesn't translate, I would already invite it over to like enough information about like what are the side effects of cutting back on medication or changing medication.
Right.
We just know that the medications change and there's been behavioral problems, but there's not enough information a lot of times provided on what the side effects of cutting back suddenly on medication are.
Yeah, so one thing I'm kind of curious about when kids are in either child welfare or juvenile justice, who does the provider convey that information to? I mean, who provides the consent, and who do they discuss side effects with and target symptoms? And as a GAL, do you feel comfortable asking for that information? Could you?
Yeah, we have authorization to get it.
To do it, yeah.
Usually it goes to the case manager. A lot
Yeah.
of times the case managers don't have enough information.
Yeah, I think the more people that are asking questions, the better for kids, to be honest. And any physician should be in a position to explain to you pretty clearly what it's being used for, what the risks are, and what the potential benefits are. You know, and actually one thing I didn't do before was really go over side effects for some of these medications. So let me just do that. So for the things like stimulants, most common side effects are weight loss, some GI upset. Kids will oftentimes lose their appetite. But in general, they do pretty well. In really rare situations, a kid will become psychotic or have mood symptoms, depression. And it's sort of an atypical response to stimulants. But again, that's pretty rare. And I'm going to talk a little bit about benefits later when we go into disruptive behaviors. For the, yeah.
I'm just gonna, before you move on, I was just gonna ask, how adept do you think psychiatrists, physicians are at noting when the child is not receiving the appropriate dose? Because we have children that have multiple medications, and then the issue is the parent giving those medications to them on a regular, proper basis? The child continues to have behavioral problems, we go and we up the dose, maybe the parent
Isn't even getting it.
reporting what they're doing. And
Right.
so I see that unless you have a
Right.
physician who is really on the ball and can kind of see that, I mean.
Right. So it depends on the medication. I mean, there are tests. So things like lithium and Depakote, you can get a level. You can actually get a level for some of the other medications as well. The other way to monitor it is, are they getting their prescriptions refilled? And yeah, but you would expect, I mean, there are other ways that you can test whether there's an appropriate response. Certainly there are standardized instruments, which we don't use enough of. And that gives you an objective way to measure whether there's a change from baseline. But an adept physician will monitor pretty carefully, and they should be seeing, if they're making medication changes, they should be seeing the child every week. Yeah. And once the child is stabilized, you can start to space it out. But while you're going through changes, absolutely. And monitoring things like weight gain and all the medical testing that should be done, especially if they're on an atypical.
Is the weekly monitoring, I mean, is that standard practice? Because it seems like I'll have, oh yeah, well, we'll see him in a couple of months. You know, they'll say, well, just change the medications, we've got an appointment in a couple of months. I think, wow, that's.
That wouldn't be a
time.
standard of practice that I would be comfortable
Yeah.
with. Yeah. Especially because when you start a medication or you change the dosing of the medication, I mean, you need to be monitoring for side effects, and a couple of months is too long for a child to have a side effect that you're not catching. Yeah. Did you have a question?
Well, just, it seems like the new medications are faster at being able to tell what the effects are. Like you said, a week is enough time.
Yeah.
Is that true?
Well, with stimulant, it depends on the medication. So stimulants, you'll know in a week whether it's effective. And you may not get full benefit from whatever the initial dose is, but you will see a change. And parents will tell you that all the time. For atypicals, you're more apt to see side effects right away. But again, you know, what are you targeting? And if it's, you know, if it's aggression and the medication is working because it's sedating, you'll probably see benefit pretty quickly. So, other questions or? Yeah.
When you were talking about behavioral treatments, I think one of the things that happens too is that when I used to see clients, the time frame, the expectation that children will improve in 4 to 6 weeks, like they would if they
Yeah.
were maybe taking the medication, and then not taking into account the disruptions that may also happen, like a move or, you know, a change, and things that kids would normally, under circumstances, be upset about.
Right.
And then they don't have the appropriate coping skills in the first place. And then those kids are then put on the medication because they're not responding to treatment. when
Right.
In fact, they are
Right.
really doing what is developmentally normal.
Right. So very good point. It takes a while. So if you consider, you know, children oftentimes will have been in traumatic situations for years or have had stressors in their environment for an extended period of time, you can't expect an intervention to undo all that within a week or a month. May take a year, may take longer, but you're absolutely right. You need to be patient. And again, you're rewiring the circuitry, and that takes time. But in children, it's very possible to do. So just to go back to some of the side effects. So for the antipsychotics and atypical antipsychotics, again, these are things like Zyprexa and Seroquel and Abilify and Risperidol. Side effects are significant, weight gain being the one that's most common. Other things are elevated bad lipid levels, elevated triglyceride levels, increases in diabetes, and all of these oftentimes kids will have all at once, and we call it metabolic syndrome. And these are all significant cardiovascular risk factors. And I think that's something in a decade from now we'll see what the impact of that has been. SSRIs, GI upset is the most common side effect with these medications. And again, I mentioned before that there are a lot of serotonin receptors in the gut, in your GI system. So not surprising that that's where you would experience side effects. In general, kids respond pretty well to these. Sometimes they get sleepy, sometimes they get activated, get anxious from them. But again, they've been around for a long time and kids do pretty well. The SNRIs, people have had a lot of problems with withdrawal symptoms from these. And again, norepinephrine works on the autonomic nervous system, so when you've got withdrawal, things like heart rate and respiratory rate, etc., can all be affected. Mood stabilizers, huge amount of weight gain, a lot of sedation, other things that you need to monitor medically with these kids. Relatively high risk for what it is that you're trying to treat, especially if there's not a known mechanism by which it's being used. Yeah?
Do those negative side effects that you've been telling about go away when the medication's withdrawn, or are some of them residual and will?
Actually, most of them do normalize. Yeah. Although there's not been really good research looking at that, but most of the kids, their blood levels for lipids and stuff will normalize for over a period of time. But again, there's residual risk, and whenever you're exposed to a cardiovascular risk factor, it always kind of stays with you. So yeah, and the diabetes question is the one that I would be most curious about, and would like to see a study on that.
So a mistake in the diagnosis and treatment with these drugs can have some serious implications.
Long-term implications, yeah, absolutely. So, any other, yeah?
Depakote, one of the side effects from that is like tremors.
Yeah, you can. Well, lithium actually is more apt to produce a tremor. Yeah.
Will that go away then after the medication is changed?
I would assume it does. I don't know the research on that, but yeah. Any other questions or, yeah?
Did I hear you correctly about the mental health screen was done in the Wisconsin?
Yeah.
Public schools there?
Yeah, so it was, that's where it was done, and it was a computer-based, less than 10-minute screen.
I want to follow up on the diagnosis, if you have the wrong diagnosis or whatever. Could you talk a little bit about the challenges of diagnosis with this juvenile justice and child welfare?
Actually, let me go through like the next two sections, and then that probably would be a good way to sort of wrap up things. So we'll go through a little bit of the biology and some of the difficulties in diagnosing kids, both because of the way the DSM is structured and because kids, they are developing, and so oftentimes you just have dysfunction across multiple domains and it doesn't really fit criteria but we'll talk about all that a little bit. Yeah.
Just had a question a while back, we were talking about it being standard practice to see that it will every week. Are there other standard practices? Because in my experience, some things like having tests to make sure if there's an indication for, problems that the kids that are in child welfare are not having those tests prior to and are just being on medications, and those things aren't being monitored, or they're being prescribed medications by a primary care physician and not being followed by a psychiatrist. Are there things that are pretty standard that you could?
Yeah, so there actually are really good treatment and evaluation guidelines, which you can find on the website for the American Academy of Child and Adolescent Psychiatry. And I think just about every diagnosis has been covered. And there are things called practice parameters, which give you treatment recommendations based on all the research. And it's www.aacap.org. And in terms of evaluation, there are some really good websites about the different screening tools that are out there and available. I'd be happy to provide that to anybody if they'd be interested. Okay, so let's go on to the next section, the treatment of disruptive behavior disorders. And again, these are most likely the kids that you're seeing, certainly the kids you're seeing in the juvenile justice system, a lot of child welfare too, a lot of the crossover kids, and certainly in schools, these are the most problematic children. So what do we mean by disruptive behavior disorders? So it's really 3 different diagnoses: ADHD, attention deficit hyperactivity disorder, ODD, oppositional defiant disorder, and conduct disorder. And what we know about these kids is, again, diagnostically, it's kind of a mess. I mean, there's a lot of overlap between the different diagnoses and a lot of comorbidities. In fact, 70% of the kids with a diagnosis of conduct disorder will also have a diagnosis of ADHD. So it makes treatment a little bit difficult, and kind of still trying to figure out what's going on with these kids neurobiologically. So a question for the audience: what percentage of youths detained in a juvenile detention facility have a psychiatric illness? Axis 1 diagnosis. Any guesses? We have a judge here, do you think? Absolutely. Yeah, 66%. And so another question to be thinking about: is there really a difference between the kids that are referred to juvenile justice as opposed to adult systems? Do you think the level of mental illnesses is the same, less, greater? I'm going to keep picking on the judge. It's actually, see, it's about the same. So the kids look pretty similar. So about 66% of the kids referred to adult courts have an Axis 1 diagnosis. So you might be thinking the Axis 1 diagnosis is probably conduct disorder. Well, in fact, that isn't the case. Most kids have something other than just conduct disorder as an Axis 1 diagnosis. So that means they've got an anxiety disorder, they have depression, they have post-traumatic stress disorder, psychosis. So it's a pretty striking statistic, I think. And the reason why we should care about this is we can treat most of these things pretty effectively, whether it's through a behavioral intervention or sometimes with medication where it's appropriate. And once you treat those things, kids actually do a lot better. And you see real improvement in behavior. And just to look at some of the most common diagnoses for this group, certainly ADHD is very common. 9% in juvenile detention facilities, 8% for the kids that are referred to adult courts. For oppositional defiant disorder, it's about 15%. And for conduct disorder, not surprisingly, it's pretty high, 37 in juvenile detention facilities, 38% in adult facilities. Now, I actually kind of am curious about why not all the kids that are in juvenile detention facilities or adult courts don't meet the diagnosis for conduct disorder. You would think, I mean, the whole diagnosis is based on illegal activities and over a 6-month period of time, but for whatever reason, that doesn't seem to be the case. Other prevalence of other disorders: psychosis, 1% in juvenile facilities, depression and other mood disorders, 22%, almost a fifth of the population. Anxiety disorders, about a quarter, and substance abuse, not surprisingly, about half the kids have had issues with substance abuse. Now, I actually think the anxiety disorders is probably a little bit low, and I think we do not do a very good job of screening for trauma in these kids. And most of these kids aren't likely to divulge information about past history of abuse or past history of exposure to domestic violence and things like that. So I would imagine that's a lot higher number. In terms of ADHD, what we do know now is this is really a disorder of developmental delay. And again, this is largely involving the frontal lobes and those areas that are involved with executive functioning. And again, these are the kids that have so we talked earlier about normal adolescent development, and all kids sort of have a hard time with working memory, with getting organized, with controlling impulsivity. But these kids have real difficulty, and I'm going to show you maybe the next slide, that this is real, and we actually have sort of mapped this out using imaging techniques. And again, so we know the biological mechanism. It's a delay in myelination and also synaptic pruning. And it is in that part of the brain where there are a high number of dopamine receptors, which makes the case, in part, that that's why stimulants are so effective. And we also know that if we fail to treat this population, their outcomes are a lot worse. Much higher incidence of substance abuse, poor peer relationships, a lot of bullying, and certainly real difficulties in academic performance. So I'm going to back out and see if we can get this up. Okay. So this actually just makes the point that there is a real difference in the development of the frontal lobes. Let's see if I can get this to run. Oh, technology. Let's try it one more time. Okay, here you can actually see. So the ADHD kids, look at how much more slowly their cortex is changing. But by the time they reach late adolescence or early adulthood, they really do catch up. Do you want me to run that again? If people see it, or
Yeah.
run it again? Okay. Okay. Oops. So now you can see on the here the healthy controls how quickly that's turning blue, and look how delayed it is in ADHD. And what stimulants actually do is they speed this up so that they actually look like healthy controls. And that's a pretty significant change. So again, this is the kind of evidence we should be demanding for every medication that we use on kids and for every disorder. And the technology is certainly there now to do it.
You said stimulants speed the process up. Is that just a temporary, or is it?
No, it actually, I mean, as long as they're on board, they continue to develop normally to the extent that they actually look like healthy controls.
What's a good age to put an ADHD child then on a stimulant medication?
A good age, I guess, when they become symptomatic, when behaviorally they look like they need the medication, and then the evidence, and this is still evolving evidence, but the evidence seems to suggest you want to keep them on until like mid to late adolescence. Although, you know, again, that's not a conclusion at this point, but there's strong evidence to suggest that's probably the best way to proceed. Yeah. Again, this is a class of medication that really does have good benefit and good outcomes for kids. Okay, so as I mentioned, the most commonly used medications for the treatment of ADHD are stimulants, and these are things like Adderall, Focalin, Ritalin. Both short-acting and long-acting versions are available. We talked a little bit about side effects earlier, certainly GI symptoms and weight loss, and the other things. And the only other warning and thing you should be concerned about is if you have a child that you're working with that has any kind of cardiac history, you do want to get an EKG. And I believe that is now the recommendation of the American Academy of Pediatrics. Other medications that are used to treat ADHD, Strattera, atomoxetine, clearly not as effective. I don't know of any child psychiatrist that will actually use that as a first line unless there is some other compelling reason. Oftentimes kids that have a little bit of anxiety in addition to ADHD might do a little bit better on this, but I don't think the results have been all that good. Alpha-2 agonists are also being used, and as I mentioned before, these are actually medications that were initially designed to treat hypertension in adults, and these are things like guanfacine, Tenex, and Intuniv. Have a lot of side effects, and there's a lot of rebound once these medications are taken off board. Certainly a lot of sedation, dizziness, fatigue, and hypotension being significant. So my favorite intervention for these kids is sports. They just do great. Get them outside, get them to play, and it really is effective. And one of the things that we're going to look at, I'm going to talk about our research program at Boys Town at the end of the talk, is really looking at whether exercise as an intervention, when it's applied regularly, can have any impact on brain functioning. Because, you know, we see it behaviorally. Wouldn't it make sense it would actually be playing out in their brains too? But no one's ever looked at that. So other disruptive behavior disorders, ones that we actually know less about certainly than ADHD, but we do have some emerging research, oppositional defiant disorder and conduct disorder. So as I mentioned, these are very highly comorbid with ADHD, and a lot of information to suggest that all these disorders involve a lot of dysfunction in the frontal lobes. And when we treat kids with these diagnoses, what are we treating? Oftentimes we're treating the same things we're treating in ADHD, the inattentiveness, the impulsivity, but also aggression. So cognitive disorder, what is it? And it's clearly something more than just illegal activity. And I think psychiatry certainly struggled with how to better subtype this population because they aren't all the same. Initially, we tried to make the distinction between childhood onset and adolescent onset, thinking that childhood onset would be more genetically driven and these kids would likely have worse outcomes. Well, the research has not really supported that. So looking at different ways to really identify and understand these kids, and a lot of people have been describing them as either reactive or instrumental in terms of their aggression. Now, the reactive kids are the ones that are really far more impulsive and will just blow at the slightest provocation. The instrumental kids are, if anybody's seen the movie Silence of the Lambs, the Hannibal Lecter character. These are the plotters. They just kind of sit back. They know how to push your buttons. They're very manipulative. So a very different expression of the pathology, although they all engage in bad behavior. In our lab, we were actually looking at another way to sort of describe this population and kind of applying the terms callous unemotional traits. And these are the kids that really lack empathy. They don't really care how you feel. They don't understand how you feel. They really don't have that empathic response, which helps them to regulate their own aggression and to alter the way they approach situations. So it's very easy for them to hurt people because they don't feel anything in response to it. So for the kids with this more reactive form of aggression, what do we know about this population? Well, two areas are really implicated. The amygdala, which is part of the limbic system, a very primitive part of the brain. And what we know in these kids is their amygdalas tend to be hyperreactive. So again, to threaten the environment, this area of the brain is pretty easily upregulated. Now the problem with that is that's what makes us fight. That's the part of the brain that signals to us there's something threatening out there and we need to respond to it. Well, for most people, the frontal lobe will then take over and control that initial response. For these kids, that part of their brain isn't really up and running and doesn't function very effectively. So they're both overly reacting, at the same time they have poor control over that aggression, which is why they have so many difficulties. They also have a really hard time learning from their experiences, so you see them making the same mistakes over and over and over again. Yeah?
Do you see a connection between this and early childhood trauma where those areas of the brain have been overstimulated?
Yeah, it's a great question, and actually we don't have good evidence to support that, but I think and that's why, again, I think we need to do far better job of trauma screening so we could start to correlate some of this stuff, but it makes sense, yeah. So for this other population, these callous unemotional kids, or these kids that lack empathy, and the other point I want to make is there seems to be a lot of overlap with these kids and what we know about autism. Again, sort of the same social skills deficits, the same lack of empathy. They don't look at the same social cues. They don't look you in the eye. They'll look you in the mouth. So just a lot of differences in the way that they function interpersonally. But what we know biologically about this population is two things. One, as compared to the reactive kids, these kids have amygdalas that are hypofunctioning, so they never get excited about anything. They don't see threat, and as a result, they never feel like they need to fight, but it's very easy again for them to engage in aggressive acts. And they also have difficulties with the frontal lobes as well, with not having really good top-down control. So treatments, again, because of the comorbid ADHD, a lot of these kids are on stimulants, and again, these medications upregulating the amount of dopamine in the brain. But as I mentioned before, they are also frequently on atypical antipsychotics, and Risperdal probably being the most common one. And again, this medication is down-regulating dopamine. So again, what are we doing? I think it's a study that needs to be done, and certainly looking at the biological markers that are associated with this pathology to see if there's been any real treatment going on. For non-pharmacological interventions, so there are a lot of behavioral interventions that have been developed to treat this population. Certainly some evidence suggests CBT, cognitive behavioral therapy, is effective, psychoeducational interventions, behavioral and multi-component treatments. I'm going to just talk about these briefly. So I think we all are familiar with CBT. It's been around for quite a while, is used with this population. And I think more effective, again, with these kids that are a bit more reactive. And again, because I do think there is a lot of trauma here, and it just makes them more aware of their thoughts and their emotions and how to connect those things in a way that's going to not get them into trouble. Thinking through a lot of this stuff. Psychoeducation also, a lot of these kids grow up in environments where social skills are not a big part of their day-to-day experience, so they really do benefit from a lot of this, and certainly benefit from learning to talk about their feelings, which helps them to organize the way they think about the world. Behavioral interventions, actually the conduct disorder kids that are more callous and unemotional benefit from these types of interventions. They really do respond to reward, and a lot of structure and a lot of consistency. And probably the most effective intervention that we've studied is multisystemic therapy, which, if anybody's familiar with the Seattle program and all the evidence-based research that's come out of it, is not only effective, but it's very cost-effective for this population. And then residential treatments, when all else fails and there are no parents to take responsibility, this is oftentimes where these kids end up. Not a lot of research to support good outcomes. Boys Town has been doing residential care for a long time and pretty effective. About 85% of the kids that are treated there end up off of medications with the exception of probably a stimulant and have pretty good behavioral outcomes. But we definitely need more research to understand what it is about residential treatment or the various components that are applied residential treatment that are effective. Because it is an expensive intervention. Okay, so I have another case example for us to talk through, unless somebody else has a case that they want to talk through. We can start with this one. So you have a 14-year-old boy who comes into your office with his foster parents, and the child has been in multiple out-of-home placements beginning at the age of 5. Presenting problems include fighting at school, problems with the law, and now the foster parents are suspecting some drug abuse. So what additional information do you need about this child to understand what the diagnosis might be and what treatment recommendations you would make?
Has he had any past diagnoses?
Yes, do you want to know what his past mental health history was and treatment history?
What happened to him before age 5?
Yeah, right. So trauma issue, attachment issues, yeah. Other thoughts?
Were his placements always foster homes, or were there any residential treatment?
And how did he respond to those different types of placements? Yeah.
What
Yeah.
medications is he on?
What medications, right, absolutely. Any other thoughts? Yeah.
Educational testing for learning disability.
That's actually such a critical point. And for kids, we oftentimes don't identify learning disorders until they're well into middle school, even into high school, because they compensate pretty well. But yeah, educational testing.
Those are effective symptoms for getting out of
Right,
the problems.
right, absolutely. Yeah.
And just the same thing, I would want to know if there's ever been any, medical complications, toxic exposure, if there's some kind of organic issue.
Yeah, and so rarely do we work that part of it up. Yeah, that's very important.
I'd like to know too, what is the permanency plan for this child? Does he have any idea where he's going to be tomorrow?
Yeah, right. Don't you think he'd want to know that? That just breeds more attachment issues for these kids. Yeah, always what's going to be the next thing and when will it happen? Yeah, all really important points. So, hit again all the important considerations. You certainly want to know all the environmental factors. And even with a biological family, with a foster family, you want to understand what's the dynamics in the home. Is there a new sibling? Are there sibling problems? One of the foster parents having any medical or mental health issues. So certainly all important considerations. With this kid was, what do we know about his biological background and what genetic loading should we be concerned about? And unfortunately with so many of these kids, we just don't have that information, which really makes it difficult in terms of even treatment decisions and how they might respond to medications, etc. Does everyone think this child is treatable? I know here in Nebraska, there's been a lot of discussion about whether conduct disorder is really a mental health issue or whether it's just a behavioral problem. And our research certainly supports that it is a mental health problem. These kids are dysfunctional and it is organically driven. I think all these kids can be treated. with maybe a few rare exceptions for some of these callous unemotional kids. Because it's not that they can't be treated, we just haven't figured out the right treatment for these kids. And if there really is overlap with this population, with the autism spectrum kids, where it really is, an empathy attachment issue, we need to start looking at the treatments that are being used for that population and applying them. And also there's a really good argument to be made that we understand the biological basis for attachment. It's oxytocin, vasopressin. And there are now some trials looking at oxytocin as a way to promote attachment behavior in both autism, and I would hope at some point to even look at some of these kids as well. But to catch it early and hopefully treat it effectively.
With the callous, unemotional group, where the treatment is, isn't there more promise with some treatments that are directed earlier?
Oh, absolutely. The quicker,
So,
the sooner you intervene.
And so being able to sort of assess that early, and that's kind of, that one does look like there might be a strong.
There's a very strong genetic component. Yeah.
But, and then if that's true, then the parent might not be as able to provide the attachment and closeness that they got it to.
It's a very important point. Yeah, absolutely.
But it does seem like identifying those children early would be.
Right, absolutely. And we have really good instruments now that can pick up these kids with pretty good sensitivity and specificity. So, yeah. So again, early school-based. Yeah. Yeah.
I have had several of the callous, unemotional style kids
Yeah.
over the years, and they're the scariest ones that I deal with.
They are. That's my research population, they are.
The thing I don't understand is, okay, they don't have the empathy, I can understand that, but I don't understand what the triggers are for the bad behaviors. They're not getting a reward for the bad behaviors other than maybe attention, but other than that, it's,
You know how I hear them describe it? It's like a self-reinforcement thing. It's almost like an obsession. The thrill they get from doing something bad is its own reward. They get an adrenaline rush. It's like a release. It is like an obsessive compulsive behavior. And again, you talk about circuitry. Yeah. But you're right, they are pretty scary. Yeah. Other questions or comments? Yeah.
Are those children that he was describing likely, if untreated or not treated correctly, to go on and have an adult diagnosis of social pathology?
Yeah, so Robert Hare has done a lot of longitudinal research on this population, and what we know is that they will continue to be they will be sociopathic for the rest of their life, but what they tend to do is kind of burn out. Their energy level decreases, and they don't actually engage in as many bad behaviors as they grow older. But the thought process is still very sociopathic, and they do manipulate, and they are deceptive, and that doesn't change. Yeah.
But there's been some recent research of a small but significant proportion of Wall Streeters have sociopathy.
You're kidding, really?
Yeah. It was
Can we say Bernie Man?
well, obviously him, but something.
Oh, yeah.
It's like 8%. Something fairly significant that is screening, and we would rather. Even though we don't want people to do that either. That's better than serial.
Well, I agree. And the show Dexter is sort of a little bit based on that. But, I think when I work with these kids, that's why I try to counsel them. Think about a career choice that is going to use who you are and have that be a strength for you. So you don't have a very reactive autonomic nervous system. No, but think about it. Car salesman. Yeah. There are a lot of, not to make any, but seriously. Or special forces for the military. Because I actually think in some ways they have similar autonomic profiles. They are non-reactive. And that's what allows you in a very stressful situation to get through it. But yeah, thinking about that, and then also, of course, providing treatments to assist. Actually think about what worse disorder could you have than to not feel empathy and to not know how to love somebody. These are just, kids
So
with...
you're saying social work wouldn't be a good career?
Nah, I don't think they'd be all that effective, but so any other questions about this group or yeah?
Well, in my adult clients, I see the diagnosis of narcissistic personality, and it sounds like the adult version of it.
Yeah.
Is that kind of the leftover when you stop with the, criminal behaviors, then you're just narcissistic.
Yeah, there's definitely a lot of overlap. There are distinctions. I mean, narcissists sometimes usually have some boundaries and aren't completely manipulative and, you know, deceptive, but there is definitely a lot of overlap. Yeah. Yeah.
Do you see the kind you're talking about that doesn't show any emotion? Do they benefit, or do you see them where they are not on any medications and they're not getting any treatment other than maybe see a counselor once a week?
I think that, to be honest, I think for that population, the only medication that probably has any impact is a stimulant to treat their ADHD symptoms. And
So no drugs at all probably isn't about as effective?
again, I would argue for the stimulants. I do think if they do have any of those characteristics, but yeah, and I don't know that therapy. There's even I don't.
Well, not even.
Yeah, that's the extent of our
I
research.
just wondered
Yeah.
if not having somebody on any medications, if that is helping them.
Yeah, I mean, I don't think there's any evidence to suggest the other medications are helping them, or treating them, or normalizing pathology. I think that's the issue. Yeah. So. All right. Any other questions or? Yeah.
I think it's looking similar to Vicky's question. I wonder about with the ADHD kids, it's been such a prevalent diagnosis, and sometimes without proper assessment, just that a child seems hyperactive,
Yeah,
you know, going
yeah.
to school setting, and then they're put on a medication,
Yeah.
stimulant medication, and then they end up having more behaviors, so then they're put on another medication. Can you talk a little bit about what happens?
Well, if they're being put on a stimulant and their behavior is actually worsening, you take them off the stimulant because clearly they're having an adverse reaction to it. Yeah.
In my practice, I didn't always see that. It was, we're going back to the psychiatrist and we're still having behaviors on the stimulant medications, so we're going to add an additional medication.
Yeah. I think there you need to take a close look at what's going on in the environment, what might be precipitating this behavior. So the whole issue about ADHD and more kids being diagnosed, it may be, as we all know, that we're better at diagnosing it or we're just catching it more often. But also, kids live in a different world today. They have a lot of stressors, they have a lot of constraints, they have very little time to go out and play. They're doing their video games, they're watching television. And, it's sort of like a breeding ground for this, these types of behaviors. But if a child is actually getting worse on a medication and there's nothing environmentally that might be, causing it, I think you take them off the medication, you try something different. Yeah, because it's clearly not being effective.
Can I ask, to what extent is there commonality in the treatment choice, the medication issues among practitioners?
Not much, to be honest. I mean, there are treatment guidelines, which I was referring to before. So like with ADHD, you try them on a stimulant. If it's not effective, you give it a full trial. You may want to try a different stimulant. And there are those kinds of guidelines, like which one you would actually start with.
The difficulty for then a parent or a caseworker, a guardian ad litem, is if the physicians are not
Right.
have commonality in their
Right.
approach, then
We're moving as a profession.
ask questions, but
How do you know whether it is standard practice if there isn't really any guideline? So I think, again, the Academy does have pretty good guidelines. It's not by particular drug, but by class of drug. And that's a pretty good way for you to assess what's going on. But there is variability. Some doctors like Ritalin, some like Adderall, some like Focalin. Sometimes it's whatever the formulary is in their treatment facility. Yeah. I wish it was more standardized. I definitely wish it was more standardized in terms of behavioral intervention, how long you need to try it before you move on to a medication, or do you need to do both? And I'm going to talk about anxiety and mood disorders, and there's a little bit more of that kind of research that's been done there. Yeah.
I have seen a significant number of ADHD kids who get put on stimulants and they respond well, and their parents, because they don't like the thought of their kids being on
A
drugs,
medication, yeah.
say, well, okay, I'll let him use the drugs during the school week, but during the weekend I'll take him off.
Yeah, and in the drug holiday issue, again, I think there's research that's emerging, that's really not a good idea. I mean, again, they fall back, and you want to keep them at developmental level. So, and I think that stuff needs to get out, that research needs to get out, and I think it will inform clinical practice. But it's evolving. Was there another question over here? No? Okay, so I think we're going to take a short break, and then we'll come back and talk about mood and anxiety disorders.